So finance in the lab is not exactly the most scintillating of topics, but it is necessary, especially if you ever plan on ever helping out your supervisor, becoming a supervisor, moving into management. You should understand at least the basics, because obviously we're not going to go into a lot of depth here, but you have to know at least the basics of what goes on as far as paying for the job that you're going to be doing. And how we get paid, so that then you can hopefully help in any efforts to improve efficiency or to improve cost per test kind of issues. So we're going to go through, this is just the basics. Okay, so now the first thing, and I'm sure that you guys have dealt with this at least in a very superficial way through your own insurance companies, but you have to understand that the way we get paid in the lab as of today requires that we use the CPT code, that every hospital, every doctor has to take part in the CPT system. CPT stands for Current Procedural Terminology, and it's a way for physicians, insurance, and the people who pay for your health insurance to understand what everybody's talking about, so that everybody's using the same terminology. But unfortunately, because of the complexity of healthcare, the CPT system, of course, is also very um, complex. And we use this system because this is the system that's recognized by CMS as the official coding system. So any insurance company that's out there is going to say, well, if it's good enough for Medicare and Medicaid, then it's good enough for me. So that does allow a little bit of overlap, everybody using the same thing. So CMS makes it the official system, which means that it's used by all other third-party payers at this point. And basically what it does is it sets up the codes not only for what the physician's doing, but also for what we in the laboratory are doing. And it sets the fees that will be paid for those services. And the types of code exist in 3 categories. Category 1 would be those generally accepted lab service codes, and those are divided by the lab sections, but they are assigned to each of the lab tests. Then we have category 2. Those were developed for performance measurement tools. So there are no lab practices, no lab procedures assigned in category 2. None of those will apply to us in the laboratory at this point, at this date. And then we have category 3, which are so that's the category of temporary codes. So this we do use this because these are codes that are set for emerging technologies. So these new procedures that might exist, they don't yet meet the requirements of having a category 1 code. So all category 1 codes at one point start here in the category 3 area. And they're only allowed to stay in category 3 for up to 5 years. If they don't get moved to category 1 in 5 years, then they get retired, because obviously people aren't using them. So hasn't been accepted by the field in general, so might as well get rid of them. Now all of the codes that exist in category 1, and you can see examples of those codes here in this chart here, you can see them in this outer column. Those are just examples. I don't really necessarily follow any particular order, but you can see that they're a little bit related to each other, of course. But they can also have what are called modifiers, which you can see over here. Modifiers are usually, well, they're 2-digit numbers that get attached to the original code, to any specific code, before you start the billing process. And what they do is they demonstrate that some service or procedure has been altered by a specific circumstance that hasn't changed the definition of the code, but they change the conditions of the code. So these are the modifiers that I've used there are used in lab medicine. There are not a lot of them, but there's a few that are used in lab medicine, and you can see that the 26 modifier is used for those procedures that include both us, a lab component, but also a physician component. So these are available only in a select number of situations, and generally these would be only for inpatient inpatient procedures. So where there's some kind of professional interpretive component, and that component is reported separately. So there's a lab component and then some physician component. It could be either the pathologist or something else. So this would apply probably a lot to cytology, histology, where there's a cytologist who's doing something, but then there's also a physician who also has a component, some kind of interpretive component there. Okay, it would apply in other places as well, but I could see a lot of this in cytology. 91 is a modifier that's used when we repeat a clinical test on the same patient. It's the same type of specimen from the same date of service, but basically we use this modifier when we need to, when we have to, obtain some kind of subsequent clinically useful test. This isn't for when you rerun a test on the exact same specimen to confirm the initial results, or anything like that. This is when you have to repeat a clinical test on a completely different specimen for some clinically useful purpose. So it's not just to verify. It can't be just to verify. It has to be for, a follow-up information, but it's on the same day. Most tests you can't do more than once on a day. So this is for those very specific situations. 59 is a modifier used to identify distinct and separate multiple services on the same type that are the same type on the same date of service, but they are not normally reported together under other circumstances. So basically, this generally refers to different encounters with the same patient or different anatomic sites. This applies to us in microbiology fairly commonly. So the patient comes in with some kind of wound, a lot of our diabetic patients, and there might be amputations, things like that. So cultures are taken. Generally speaking, you're only supposed to have one culture per site per day, but the physician chooses to take a superficial culture as well as a deep tissue culture, potentially even a biopsy culture. They're all from the same site, but they're different types of specimens, even though they're from the same exact site. So a lot of times this might apply to us, to many of our circumstances in the micro lab. And wound cultures are a big one. You take it at the site. Surgical cultures as well. You take it at the superficial site, and then deep wound cultures. It's the same leg or toe or whatever, but the depth of the culture is different, and there is a clinical reason for that. And then 90 is a modifier that's used to indicate that the lab has referred a particular procedure, that it is billing to a reference lab. So if we don't perform it in-house, we might add this modifier to this. In this case, we might end up billing it, and then what we have to follow is what's called the 70-30 rule, which states that no more than 30% of the total testing for that lab, for an accredited lab, can be referred out. So if you are a hospital laboratory that is sending out more than 30% of your work, the question becomes, why are you there? So the general rule is that you have to actually do the work yourself, as much of the work as possible. So that 70-30 rule applies here. So these are just a few of the modifiers, and you should know what they mean and why they would be useful. Okay, one hospital might perform, say, I'm trying to think of a send-out test. They might perform some PCR outside the hospital because they don't have the facilities to perform PCR in-house. Another hospital might perform it in-house. So the 90 modifier goes to that. The billing, generally speaking, you just pass along the cost of the test. We really don't add in anything. You don't make a profit in a hospital lab. Some of the other things that you should definitely be aware of that have to do with billing, and I'm sure you've heard of it before, is the advanced beneficiary notice. An advanced beneficiary notice is a statement of potential charge to the patient, direct charge. And this applies mostly to your Medicare patients, but basically if the hospital is aware that a particular service that the physician is asking for will not meet Medicare payment rules, so this applies to your Medicare patients. So we know that we know in advance that Medicare is not going to pay for this. If we know that in advance, then we need to get what's called an advanced beneficiary notice signed by the patient, which states, okay, the doctor is ordering this test, but it's very unlikely that Medicare is not going to pay for it, which means that the cost is going to be passed on to you, the patient, and you will have to pay for it out of pocket. That has to be signed in advance. If your Medicare patients are not notified of that, then it's very likely that you have to eat that as a hospital. Okay, so what does that mean for us? One of the rules about advanced beneficiary notices is that you just can't hand them out like candy. You can't just get every Medicare patient to sign advanced beneficiary notices. There has to be a policy where you are actually examining what Medicare will pay for and what they won't pay for. And if you know that they won't pay for this, then in that case, you have to hand an advanced beneficiary notice to the patient. And then finally, of course, you probably know, you've been working for a hospital, you know that hospitals don't actually get paid what it costs to run a test necessarily. We get paid by capitated services, which means that we get paid a predetermined amount for the management of any specific disease or specific clinical circumstance. So basically what that means is we get paid by diagnosis, and the diagnosis code has to be accurate. So if a patient comes in with pneumonia, say, you get paid a predetermined fee that you've negotiated with CMS and any of the other insurance, that this is what they pay for a case of pneumonia in your hospital. So your hospital has to kind of figure out what it costs to pay to treat pneumonia. And if that means that you expect the patient to be in-house for 4 days, then you include that cost and what medications and all that stuff. If your patient gets, they're only in-house for 3 days and you manage to treat them slightly under cost, that's good for you. But if the patient is in-house for a week and a half, there's no extra fee for that. Okay, so that's all based on the diagnosis. Okay, and so those diagnosis codes, they're different from the CPT codes. The diagnosis codes are related to what the doctor actually diagnoses the patient with. So that diagnosis code will be associated with what affects us in the lab as diagnostic related groups. These are tests that are associated with a specific disease or condition or medical situation that will qualify under capitated services. And this applies to every inpatient. Outpatients are a little bit different, but we're very interested in hospitals because this applies to every inpatient. And what that means is, so we had the theoretical case of the patient who comes in with pneumonia. Well, there's a certain group of clinical lab work that are expected to be run on that patient. And actually there's a time frame and all that stuff where it has to be run. And if you don't, you're expected to run them. If you run extra, that's on you. If you don't run enough, they're going to be asking you, why didn't you actually treat the patient the way we agreed that you would treat the patient? So, and then that can affect your payment as well. And these are called, in the development, they're called clinical pathways or care paths. So these have these care paths have been developed to be associated with a diagnosis code. They include diagnostic related groups, the tests that belong to them, and they're what set the predetermined costs related to that specific diagnosis. Now, admittedly, in any one of these, the lab costs generally are a pretty small percentage. Really, it's how long is that patient going to be in-house? That's the real cost. But it's our job in the lab to be able to identify what the lab costs would be for any one diagnosis and be able to keep our costs per test updated so that we know exactly what it's going to cost us to care for these patients. You know, the days of just saying, oh, well, whatever it costs, we want to get everybody better, it doesn't work that way. We need to make sure that we can justify the running of this lab by paying for it. And it's already hard enough to get paid for, you know, we're a cost to the hospital. We don't make money for the hospital. So there is a program that's associated with diagnostic codes for outpatients, but that's actually pretty preliminary at this point. Outpatients are much more difficult to manage as it comes to that, but inpatients are highly managed. And it's one of the reasons why hospitals want clinics, which are technically outpatients. They want to move you into clinics because inpatients are highly managed by the insurance companies, and the decision making is very limited. You're stuck with that diagnosis. This is what you're allowed to do. If you go outside that, it will not be compensated for. So might happen anyway, but you have to understand where you're leaving the system. Now the ICD-10 codes, these are the codes that are associated with the diagnosis. So these are your diagnostic codes, and you can have more than one ICD-10 code associated with any one patient. Okay, you'll basically build a clinical picture with all of the ICD-10 codes that are that apply to that patient. And there are a lot of iterations. These are constantly being changed, which is pain in the neck to billing. And for our purposes, we never apply these, but this is basically the backbone of how we decide what tests can be run on this patient. If you have a patient who comes in who's, say, you know, a 42-year-old man, you have to be able to explain why that man is getting, you know, any one of the tests, and they have to relate back to these ICD codes. Now, just to show you the iteration, so IDC-CM is one iteration of the names, ICD-9, ICD-10. You can see there's a bunch of different formats. The ICD is always the prefix. This is always the prefix. Then you have 9. These are all various iterations, formats, I should say, for any of the types of codes that you might use. But these have to be generated by a physician. And what's important for us is they can't be post-dated, they can't be changed. So the doctor can't say, you know, well, I really want this test over here, so maybe I'll say that the patient has, you know, hyperglycemia so that I can get a glucose tolerance test run. Okay, you can't do that. You can't backdate it. That would be considered fraud, and you'd be in violation. It's a pretty big fine. Okay, not to mention it is actually they could technically, you know, take you to court over that. So this is just some examples. There are constant changes in here, and this is what we use to determine if there are acceptable tests that can be associated with these codes. Okay, you can't change them to try and fit the tests that you want, is the key thing. If we look at the billing flowchart, you can see that it gets pretty complicated. It's no longer just write up what you want and then go on from there. You can see it has to start with the initiating order from the physician. Okay, is there going to be, and from that order, the hospital has to determine if an advanced beneficiary notice will occur. The patient can decline that. If they decline that, they are declining the test. The hospital does not have to run a test for which it won't get paid. So, and that's another reason why the advanced beneficiary is important. You have to, counsel the patient, okay, this test that the doctor's ordering, it could help you, but it might not get paid for by the insurance, in which case you would have to pay for it. And if the patient says, well, no, I don't want to pay for it, there is no requirement that the hospital perform the test. So that's why this step is very important. Once you finish that part, you initiate the order by logging it into the, well, usually it's logged into the hospital information system, but it eventually gets to the laboratory information system. That system has to have some information about the patient, the demographics, the who's going to pay, that's the insurance information. You can't necessarily see all this stuff, but it is there somewhere in the background. Then the test requests, the diagnosis, and the advanced beneficiary notice status. Have they accepted or declined it? And this might change over time. You might need to do some conversions as the patient either decides, well, maybe I will do that test, or maybe I'm going to, if there's any diagnostic updates or anything like that, that can happen along the way. And requesting missing or incomplete information, this part here, if we don't have the information to perform the test or to request the test, then that step has to be followed by our processors and by our clerical aides. They're very important to make sure that we eventually get paid for this stuff, okay? And then we assume that the test is done. Only when the test is done will the claims processing software accept or finalize the request to get paid, that becomes important to us because you have to make sure you verify your work. You might have results in the computer, but it was never verified. That usually is a step, it's a limiting step that the technologist has to complete. So you have to make sure that that verification step is finished and that it's released to the floor, because that's the only place where claims processing will start. Again, incomplete claims will go back and forth if there's the insurance company or whoever's paying, the payer, says, oh, this isn't complete, they'll request more information. Eventually you get to a clean file, a clean claim here, where all the information is there and you can send it off to your insurance company and post it. If there was a copay, that copay will be applied to that particular claim, and then again, eventually, it might get denied, might have to be appealed, those kind of things, and eventually might be billed to the client or patient. Most of this we don't see at all, but we do occasionally, in particular in these two sections here, we get a lot of requests. We get requests occasionally, to clarify a particular order or a result, make sure that a result is finished before we finish a claim. In particular, we have that issue in micro. Things take a long time to be finished. They want to finish out the claim, and lab results aren't in. Think of a TB request or a fungal or a viral culture. They could take up to 4 to 8 weeks to be finished. Might take a while before it's complete. It also comes into play with our send-outs, because before you file a claim before you completely file a claim, you have to make sure that all the results are in, and that does become an issue upon occasion with our send-outs, making sure that we got the results back and that they were properly filed in the LIS so that the claims can be sent through. Now for laboratory services, there's a few things, a few sections or categories, I should say, that apply to our services. We have diagnostic services, and that's probably one of the largest categories for us. And these are used to identify any physiologic abnormality associated with the disease. That's the majority of what we do. Then there's 3 other categories. Monitoring tests, which we use to follow the progression of a disease, or response to therapy, or just detect side effects. Those things So these tests, the patient already has to have an established diagnostic code. So if your patient is diagnosed as diabetic, a glucose level moves from a diagnostic service to a monitoring test. And the reason that's important is because while diagnostic services can happen at any time illness is suspected, a monitoring test is limited in the number of tests that you're not allowed to have a glucose done by a laboratory every single day as an outpatient just because you're a diabetic. If you're an inpatient, you can have a glucose test probably only done once per day, not 7 times a day, at least in the laboratory. We do have the glucose monitors, the finger tests that are available on the floor, and they'll only pay for one or the other, not both, a certain number of times, okay? If a patient is defined as having kidney disease, we'll do a urinalysis on the patient. So we move from a diagnostic urinalysis to a monitoring urinalysis, and those things are limited in the number of times that they can be done each day. Then we have screening tests, and tests get moved into the screening protocol from time to time. A lot of times associated with what's going on in the news or the media, things can get moved on here. So a screening test is done, there's no sign or symptom of disease, but we're going to just screen a particular population and to look for the disease. And this is usually to find those things that respond well to early treatment. So PSA, for example, it can be a diagnostic test, but for most men, it's a screening test. And so the PSA is done to screen for the presence of potentially malignant cells or at least hyperplasia of the prostate. It's not a monitoring test. So if the patient has been diagnosed with prostate hyperplasia, then it might move to a monitoring test, and from there potentially to a diagnostic test in the first time or that it's done. And then the fourth category, which admittedly in the laboratory we have relatively few, there are some tests that do require pre-authorization before they're done. So these are tests that you would be doing either outside of a diagnosis code, so they don't seem proper for the diagnosis code, so you'd need to get pre-authorization. This mostly results, other tests, I'm sure you've heard about it in radiology and other tests like that. In the laboratory, there's still a relatively limited number of diagnoses that would require pre-authorization for any of the tests that we have. We just don't have that many controversial tests. Okay, although there are some, and the ones that come to my mind anyway are the microarrays that would be used in cancer screening. So BCR gene detection, the genetic markers for that relate to cancer risk, most of those still require pre-authorization. Okay, so those are they're relatively limited number of tests, but the big thing is that depending on which category you're assigning that particular test to, it'll limit the time and the number of tests that can be performed. And then there are rules and regulations that apply to reimbursement, to how you get paid. So there are certain required elements as far as when you submit your claim, whether or not you'll get reimbursed. And these elements are required by CMS. And so all third-party payers other than Medicare, Medicaid require the same things. So it gives a little bit of standardization. Basically, we use CMS rules and we apply it to pretty much everybody else. They can change it a little bit, but pretty much apply it to everybody else. And those include, you have to have the unique patient identifier. Pardon me. You have to have accurate date of service. I've had a number of calls from billing on this because the date of order is not necessarily the date of service, and sometimes the date of service extends over a period of days and things like that. So they want clarification sometimes. the bills that apply to that service. So that really is the tests that we are doing. The ordering provider number, so that's the doctor's number. The provider CLIA number and designation, so the lab's number, which allows, the designation refers to, are you a high complexity lab, or is the test a high complexity, moderate, or certificate of waiver, that kind of thing. So what kind of lab test is this? Place of service, the actual service provided, that's the CPT code, and the diagnosis code. Those things are all required before a claim can be considered complete, before it can be considered for reimbursement. They won't even look at it until all that information is provided. And then we have what are called procedure edits. So again, those codes that we have can frequently be modified in some way to suit the circumstances that they were performed under. You have basic edits, which evaluate the procedures that were performed and determine if the frequency of those procedures was appropriate. So this is how both the billing department and the insurance company are going to analyze the codes and the procedures that come through. So if something was performed, let's say, remember one of our most common things is you're pretty much only allowed more than once a day. So if something was performed more than once a day, then you're going to need a modifier in there to explain why it was medically necessary. So these are the things that should stand out to you in billing and in the laboratory. So if something comes up and it says, wait, we already got a urine culture on this patient, we're mostly going to have to reject that. If we don't reject that, we need to have an explanation as to why 2 urine cultures were ordered on this patient in the same day. National Coding Initiative, or NCC, a National Correct Coding Initiative, which is NCCI, is an effort to determine if 2 or more different codes are appropriately ordered on the same day of service. So this, there's a whole bunch of systems in place. Most billing departments have this already built into their hospital information or their billing systems in order to correctly assess if a particular two separate codes are mutually exclusive, like you couldn't have done both of these on the same day, something like that. Okay. Then we have what are called comprehensive or component edits. These identify cases where a specific code has been identified as representing a component of a more comprehensive code documented on the same day. So what this applies to is, for example, there are cases where you would perform, there are several cases where you perform, for example, more than one CBC on a day if you are monitoring, say, anemia in a patient while you're treating it. If the first time in the morning the patient gets a CBC, they note that the patient is anemic, so they receive a transfusion, say, and later on the physician wants to see how the anemia is responding, but instead of ordering a CBC, he orders an H&H, which is perfectly reasonable and makes complete sense. He doesn't really need the full CBC, just an H&H will do. Well, there have to be components, there have to be systems built in to detect, wait a minute, the patient had a CBC and they had an H&H. Is this an example of duplicate testing? Because if the patient had 2 H&Hs on it the same day, that's usually not allowed. But because they're not the same name, it might be missed. So there have to be systems in place where you explain, well, all we're doing is watching the anemia, making sure it responded to the transfusion. And so it does make total sense, but there have to be systems in place. And basically this is ensuring that fraud isn't taking place, okay? Because CMS does not trust anybody. And then we also have to have systems for mutually exclusive codes. same basic thing. These are codes. You have to have mechanisms in place to identify codes for services that are not reasonably performed on the same patient in the same encounter during the same patient encounter, since they would provide duplicate information. So you can't, generally speaking, you have a CBC with diff and a platelet count. Those are the same things. This applies more to other more procedure codes in other labs, but certain ones it can apply to us. You have a Chem 7 or you have a complete metabolic profile. Why would you order both, right? The complete metabolic profile includes the Chem 7. Why would you order both? So these are things that you have to be able to identify. Okay, then we have to consider also the things. So we have the required data for our claim. We have all the edits that have been screened for by our billing. They're going to be screened for by the insurance. Now we have to also assess the conditions of the patient's coverage. So is the procedure performed? Is it medically necessary? That's one of the first things, and that's going to apply to pretty much every provider, CMS down through. If it's not medically necessary, you can't just perform. I can't. You can't send a patient in and say, I'll look for tumor markers just because it seems like you're here. That's not medically necessary. It has to be related to the diagnosis code that you're bringing the patient in on. Then you also have to look at the national coverage determination. So these are titles that are applied by CMS, not by us. So basically, what this relates to is the use of a negotiated rule, which makes a process to develop a national coverage administration policy. This relies to Part B clinical diagnostic services. So this really does apply to CMS. Each individual insurance company will have different negotiated rules, and frequently different rules that apply to different institutions or different insurance carriers. So, what is covered at Sloan Kettering might not be for the employees at Sloan Kettering might not be the same things that are covered for the employees at another hospital or another business somewhere else. So national coverage determination refers to what is covered under Part B of Medicare. Local coverage determination relates to what is covered by any regional contractor. So that's what I was talking about before. What's covered for Medicare patients is not the same as what's covered for Sloan Kettering employee or a Marist employee or anybody out there. So there hasn't been an insurance create yet will cover everything, and it's your job, the patient's job, to really know what's covered. But the hospital is required to know as well. For CMS in particular, the hospital is required to know. Now, the screening tests are special circumstances. Historically speaking, screening tests were never covered because they wouldn't be associated with any diagnosis that you had. It's a screening test, right? So at the time of the test, since you didn't have that diagnosis, it shouldn't have been covered. In 2008, the Medicare Improvements for Patients and Providers Act gave CMS the authority to add these screening tests and preventative services. And basically, that's based on the published data of the value of those tests. And private insurance companies followed along. So there was no coverage for these things previously. Most private insurance did have coverage for screening, but CMS didn't. Medicare didn't. So if you went in and you wanted to be screened for cervical cancer and you had Medicare, you couldn't get a pap smear because you didn't have a diagnosis of cervical cancer. So since then, you can see that Medicare has added, and this is a chart of screening tests to date, of the screening tests that a Medicare patient, so this applies to your patients 65 and older, of what tests could be done and how often. You can see some of them are a little bit ridiculous. Your cardiovascular disease risk is only going to be assessed every 5 years. You're over 65, you're only going to get a cholesterol, lipid, and triglyceride every 5 years. That seems a bit ridiculous. And the reality is that you can get a physical and it can be included in that. Colorectal cancer every 12 months. Diabetes, if you're at high risk, not every person, but only certain people, they'll get a fasting blood glucose up to twice a year. HIV every 12 months or up to 3 times in a pregnancy. Now, some states have other laws. HIV testing has to be offered in New York State to everybody who visits an emergency room. That's relatively, I guess not new anymore, I'm just old. Cervical cancer, pap smears every 24 months or 12 if you're high risk. Prostate cancer every 12 months, and STDs if you're pregnant. Not a lot of 65-year-olds are pregnant, not an issue as often, but if there is a risk, then you can get STD testing. For some other conditions that are specialty experimental testing, and that does apply to us in the laboratory. If it's a newly developed test, one of the things that you really need is the FDA to clear it. If the FDA doesn't clear it, it's going to be considered experimental and it's not going to be covered. So you have to have that FDA clearance in most cases before Medicaid will pay for it. And then there's a couple of special coverage conditions that apply to certain disease diagnoses, and that includes end-stage renal disease or ESRD. There are really complex payment rules. There's a whole, this one actually is so special. There's a series of rules that are both capitated as well as fee-for-service, and that's because end-stage renal disease is it's pretty complex and it requires really moment-to-moment decisions as to how to treat this patient. They could be going one way or the other. Basically you get, the hospital gets a composite rate payment through Medicare contractor, but then they have to bill separately for up to 50% of the tests that are end-stage renal disease could require an awful lot of testing. But you see it's end stage, so a patient literally has to be dying in order for this to apply. There's also, it doesn't really apply to you, well, I suppose it could, skilled nursing facilities. Reimbursement at a skilled nursing facility should be bundled into a single composite payment, prospective payment. So basically the patient is admitted to a skilled nursing facility by diagnosis, and basically their payment will be applied to the entire visit based on the diagnosis that they came in with. Okay. Then they have some ambulatory payment classifications. This is the outpatient program that CMS has in place that they're developing. The lab is not part of that yet, but eventually I imagine it will be. It's still under development by CMS. Again, inpatients, all done by diagnosis-related groups. That has to be the way it's done. And one of the things that has come into play in the last 10 years, but which is a big problem for the laboratory and for hospitals in general, is the 3-day window rule. Lab services performed 3 days prior to admission are going to be included in the diagnosis-related, in that grouping, DRG grouping payment. And so that means that your pre-admission testing, that's why it's got to be done in those 3 days prior. If it's done 3 days prior, it's going to be grouped in. A lot of times the hospital wants you just before that 3 days so that they can bill it separately. Now, compliance with reimbursement is an enormous part of, has to take an enormous part of your hospital's attention, because the fees, the fines that are applied to errors in your reimbursement compliance they're always considered, any mistakes that are made, whether it's an honest mistake or not, will always be interpreted as fraud and abuse, always. So there's no allowance for mistakes, okay? And so those fines are immense. So some of the things that apply to us in the laboratory for fraud and abuse, we don't do billing, but we might be aware of the fraud and abuse that occurs. We do have to take steps to report and hopefully correct those errors, okay? Anytime you're providing an incorrect diagnosis or misrepresenting a diagnosis to justify payment, that's obviously fraud and abuse. So incorrect coding is a big thing. You have to make sure that the codes are, that the tests that you're doing make sense for the diagnosis that's there. In many hospital information systems, there's spaces, in labs information systems, there's a space there for diagnosis. And if you see the diagnosis doesn't match the test that you're doing, you might want to bring that to somebody's attention. Probably in the laboratory, one of the big things is billing for services not performed as ordered. You can't change the order. If the order comes down a particular way, that you have to have the order changed. If you know it's wrong, you have to have it changed by the physician before you start the test. You can't bill for a test when you know it's incorrect. And you can't change the way you do it if you know, you're not allowed to. The doctor has to do that. One of the other big things for the lab is unbundling or exploding charges by billing for individual codes rather than by some kind of panel code or comprehensive code. So, for example, we bill for a CBC. That's actually a smaller bill than if you were to bill for an H&H plus a diff plus a red cell count plus a white. You can't do that. You have to bill for the bundled code, okay? And it also, a big one it applies to is chemistry. Make sure that if you know that the doctor has ordered all the components of a, comprehensive medical panel, comprehensive metabolic panel, but they've ordered it individually instead, that's not allowed. It has to be bundled together. Most of the time, the LAS has mechanisms in order to do that, to bundle them. Referring of a test to a lab facility in which the ordering provider has a financial interest. This is a big thing. Just because the doctor owns a piece of LabCorp, he can't force you to send, he can't ask you to send, he's not allowed to even ask you to send specimens to LabCorp or whatever referring facility that is. In most cases, the physicians, the ordering physicians, are really not allowed to have financial interest in those, which is unfortunate. And basically, a lot of them do the blind trust in order to avoid that. Routine waiver of deductibles or copays on non-Medicare patients, or offering charges lower than accepted market value. This actually refers to which used to be a big thing, which was the sort of the doctor's wife comes in, because it's the doctor's wife, she doesn't have to pay the copay, she doesn't have to pay the lab fees, we'll just eat that. It's not allowed. It's considered kickback. It's against the law. Okay, so bills have to be paid. And so you can't, it truly used to happen, especially doctors' wives, used to get highly offended if you even asked for their insurance information. The reality is they have to give their insurance information. It's required. Okay, and you have to bill them. Soliciting or offering or receiving a kickback in exchange for receiving business. So because we get our lab, because we decide to go with Biomurio for a particular test procedure, they decide to buy us all tickets to the Super Bowl. That's not so cool. I'm not allowed to do that. Okay, that's called a kickback, and it's not allowed. And it's actually against the law, and you will be prosecuted for it, potentially. But the fines are just terrible. So in the effort to ensure that all of these things, incorrect coding, medically unnecessary testing, improper billing practice, the exploding or breaking apart comprehensive panels, or billing for tests not performed. All of those things, if they're done, your hospital is not only it's actually committing fraud. It's committing fraud and abuse, but the amount of money that's going to be lost through the fines is mind-boggling. And so, hospital has to have some kind of compliance procedure in place, some kind of compliance program in place. And there are 7 elements included in that, a minimum of these 7 elements, where there's number 1, written standards of conduct for accurate ethical and legal practices, all 3 of those, okay? Then item 2, there should be a chief compliance officer or CCO who's charged with procedure and protocol development, education and training, as well as auditing and monitoring of the system. The chief compliance officer has to interact with both a formal corporate structure as well as some kind of institutional compliance committee, and together those have to report to the CEO. So the CEO is not allowed, you're not allowed to put this together and say, yeah, talk to the billing guy. I don't want to. They have to report directly to the president. And the reason for that is the CEO of the institution can never say, I didn't know. They have to report to him. Number 3, there should be an effort to provide standardized education about compliance. So the effort shouldn't be to teach one thing to billing and another thing to the lab and another thing to the physicians. Really, everybody's supposed to learn the same thing. You can have extended training for billing, maybe, obviously, but really you have to start primarily with the same kind of compliance for everybody. Everybody should know the minimum, okay? So it has to be mandatory. Everybody from the physician from to the housekeeping, everybody has to be part of compliance training. Then number 4, there must be defined processes for the receipt and documentation of complaints, including an opportunity for anonymity. So there has to be a process in place for people to complain about the compliance for the billing practices. And there has to be some kind of system which will respond to those allegations of fraud and abuse, as well as disciplinary policies that clearly outline the consequences of violations. And the CMS expects a zero tolerance approach. So you don't get there's no warning. There has to be consequences right away. That was number 5, the system for responding to allegations. Number 6 is the compliance program must include some use of ongoing monitoring and auditing tools to detect compliance problems. So whether you develop them yourself or you use outside benchmarking or compliance monitors, there has to be something in place to measure how effective your policies and procedures are. And then finally, number 7, your compliance program must specify the processes for remediation of identified problems. So if you have identified a problem, which you always do, or an individual, whether it's a procedural problem or an individual, what is the process that's going to happen that you go through for remediation of that problem? Because the end result is, if you don't actually identify these, part of the remediation has to be, if you have a doctor who's not following the rules, that doctor will be removed from his ability to participate with Medicare. So you'll not be able to use him anymore. So these are the things that have to be included in your procedures. And probably one of the things that will affect every part of the laboratory is record retention. So there's a lot of different standards for this, and basically you have to keep the highest requirements and keep those for your requirements. As for hospitals that participate in federal programs, basically you want to be able to go back 5 years and find any records that apply. Now, not necessarily all records have to be kept for 5 years, but as far as billing goes, all billing records have to be kept for 5 years so that they can come in and audit the last 5 years, it's a running 5 years, of records that have been applied to, that have been, submitted to CMS. Now, the accreditation standards that are required, the paperwork that's required to meet accreditation, in particular accreditation by Medicare for Medicare participation, all of those records have to be kept for 5 years, and that would be a running 5 years, so that Medicare could come in and say, okay, we accredited you, we want to keep making sure that you have all of those bullet points kept up to date for every 5 years, any 5 years, I should say. In the laboratory, what we're really concerned about are the individual everything from requisitions to results. So according to CLIA 88, we're required to keep any test requisitions for 2 years. Most of our requisitions are digital, so usually isn't a major problem, but a lot of our outpatient requisitions might come in paper, and so we have to keep those for 2 years. Just converting the paper requisition into a digital file, that doesn't fly. You actually have to keep the requisition, okay? Now you can scan it and keep it in a microfiche, and that certainly makes it easier. Testing records, the records of the results, according to CLIA 88, requires us to keep them for 2 years. So those are the records. A lot of those records for our purposes are our worksheets and our pending logs and our all of those logs that we print out and use throughout the day. We have to keep them for 2 years after they're filed. The exception is blood bank, transfusion medicine records, according to CLIA 88 as well as AABB, have to be kept for 5 years. So those, all of those records, as far as the worksheets and the panels and all that stuff, they have to be boxed up and filed for 5 years. Again, a lot of these things you can scan onto microfiche, and that's still considered fine if you have an extra 5 or 6 clerks who want to do that. But it is possible to do that. And it's a huge thing at the end of the year. You do all this transferring of records over, emptying the binders and filling the binders and all that stuff. It's a huge job at the end of the year. And you end up with these bankers boxes everywhere. It's really a pain in the neck. Cytology slides, those are the actual slides that are made of the, whatever biopsy that you have. They have to be kept for a minimum of 5 years. You can keep them longer, but they have to be kept and accessible for 5 years. It can take a lot of space. And remember that this all applies. These are all the requirements that CLIA and AABB and JACO and all that stuff, CMS, have applied. But civil actions can be initiated up to 6 years after the date of a claim presentation. So many hospitals choose to keep this stuff longer or digitize it so that they can keep it, keep some kind of copy for their own protection longer. Budgeting. So obviously finances cannot be considered completely without considering budgeting, how we budget for anything in the laboratory. And in most budgets, we're talking about 4 different phases. I don't know why everything likes to be separated into 4 phases, but that's the way it is. It seems to be. Everything is separated into 4 phases when budgeting is no different. So the first phase will be developing your goals, and this will be based on the mission of your organization and any strategic objectives that you as a management team have developed. And then the second phase is going to be your budget assumptions. basically, this is where the predictive capabilities come into play. Your organization has to be able to provide some kind of forecast for that of the monies that are going to be available. And this will be based on past earnings, obviously, as well as cash flow, what other strategic objectives are occurring in the organization. It'll be based on past earnings, changes in reimbursement that might occur. You know, they're predicting changes in the way the government reimburses. Certainly, as Obamacare goes into and out of, who knows what's going to happen over the next year or so. These things are, you have to attempt to predict this. Now, it's not always going to be right, but you have to attempt to predict this over the next year. And then, so that's your administration has to provide how much money do you think you're going to have over the next year? That's provided to you in the laboratory. And the laboratory is then got to provide a prediction of, well, how much do we think it's going to cost to run this lab over the next year? And that'll include things like capital expenses. Most capital expenses will be calculated in 3-year cycles in most institutions. Any institution can change that, obviously, but 3 years seems to be a pretty good predictor in the lab because you have technical changes that are going to occur. That 3 years is about right. And that, let's see, so that allows you, those 3-year cycles allow you to justify, are you going to replace equipment this year? Are you going to wait for another 2 years? That kind of do, and that allows you, those cycles allow you to justify the forecast that you're saying, well, we need to replace new equipment now. It's really old and the technology is outdated. Or maybe it's some kind of equipment that you use all the time. We have to replace this because our use of it is increasing. Those are all things that you're going to use in your forecast. Other things, operational expenses. Most hospitals will do this 12 months. What does it cost to run this place based on the salaries of our staff? What are our fees to reference labs? Any education that we're going to be doing for our staff, travel, chemistry, and all the 4 in the different branches with chemistry, hematology, micro, transfusion medicine. What are the updates that they're making to their labs? The changes that might occur, the cost, reagents, those things that they require over the next year, as well as any leases for equipment and reagents or maintenance that apply, as well as other direct expenses. So inspection fees, CAP surveys, certification fees, that kind of stuff. And then phase 4 is the monitoring phase. Once your budget is implemented, you have to monitor to make sure that what you predicted is actually what's happening. And this is both done in an operational sense on a monthly basis. So variations can, so you're supposed to monitor this hopefully on a monthly. You don't want to find out too late that you ran out of money. And just to give you an example, so when I was coming up, I was in Patterson, I was in charge of the send-outs to our reference lab out of our microbiology department. And a new test had been developed, and it was a viral load for the HIV virus. It was finally developed, and it was considered right away, very useful clinically. And so we predicted in January, it did actually come out around the change of the year. It came out toward the end of the year, so really use of it was going into play right around a new year, so meaning a new budget year. So based on what the doctor said, yeah, we would probably want to see this about every 6 months on our patients. So this would be useful. Yeah, I think we're going to use this. So we predicted, based on the population of all our clinics, doing this twice a year on every patient in every clinic. And we did have a lot of clinics. And by doing that, and then the cost of the test, this would be a reference test, so it wouldn't require any instrumentation or anything like that for us. It was all send out. So we passed the cost along. So we predicted what the cost for that particular part, that particular test would be over the next year. So what do we find out? Well, the physicians didn't quite accurately represent how often they would use it. Instead of doing it every twice a year or every 6 months, they actually did it with every visit. They did a new viral load on the patient to monitor the drugs that they were using, and they wanted to monitor it instead of every 6 months. They monitor it every single visit. Now, for most patients, the minimum number of visits that they would have would be once a month. Some were more often, but for most patients, it was once a month. That means our costs, we overran our costs in 2 months because patients were being seen, many patients are seen almost weekly if they're very ill. But we were overrunning we knew we were going to overrun our costs in 2 months because every single patient got another test that next month. So we were like, whoa, 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 wait a minute. So what we had originally budgeted to be, let's say, $1 million for round monies over the next year, we knew we had already spent, or the money we could predict was going to be spent in about 3 months, that it was going to be gone. So this was an enormous budget overrun for us, and it was based on bad forecasting because we got bad information from our physicians. And one of the things that's important for this, for the laboratory, forecasting, you can see, and it doesn't always work well. It depends on the information that you get. But one of the things that's totally under our purview is cost per test. We have to know the actual cost per test. We can't blow it off. We can't say, well, I know it's going to take one test, one technologist this long to do this test, which costs this much in reagents, therefore I can predict the cost per test. And then in practical speaking, I find out it actually takes 3 techs, twice as long. And they need twice as much reagent in order to do that test. I have to be accurate because this is all information that I get from my sources, okay? And you can see here that knowledge of budgets by segment, if you look at this little graph that's given here on the left, knowledge of lab budgets by segment, a little bit different than versus the regions by segment. You want these things to match up a little bit better. So just to do some basic exercises in this process, all of this lovely math, which I know you all love, it just goes to look at something that helps you to predict as you move from an old test to a new test. How am I going to predict what it's going to cost? Am I going to make money or going to lose money on this? So in this particular case, this is an example of a laboratory that was moving from the conventional Pap smear, which they already knew the costs for, to the newer ThinPrep Pap test, which was actually more costly in supplies and things like that. And they had to try and predict the cost, what was going to happen to their reimbursement for those over the next year. So what we're looking at here is the cost per test versus the reimbursement for that test. The new test would have higher reimbursement because it was considered more that it was considered a better test. So you had the conventional test, which we already knew the reimbursement, and the reimbursement was going to stay the same, but this lab was going to offer the ThinPrep and not let go of the conventional prep. So the one prediction they had to make was, well, what percentage of our doctors are going to stick with the conventional and not switch over to the ThinPrep? So they did a survey of their doctors, and then they made a prediction that they thought that about 40% of their doctors were going to stick with the conventional Pap smear. They were not going to cross over and do the the thin prep. And so you can see on this chart here, here's your 40%, they're going to stick with your conventional, meaning 60% are going to move over to the new thin prep. So what we have up here for these two tests in this chart up here, you have the screening costs, that they cost the same to do. The operator, so the processing operator, the technologist, same, cost the same. However, the reagents are considerably more expensive for the thin prep pap test, which means that the cost to the lab, okay, the cost that we have is going to be considerably more on the thin prep pap test than versus the conventional smear. So that's our starting place. So this is our cost to the lab. We know it's going to be higher, but what's the reimbursement? So the reimbursement for the PAP, for the thin prep, you can see is considerably higher across the board, each of the different insurances that are accepted. You can see that the thin prep reimburses considerably more over the pap smear. Medicare pays about $10 more for the thin prep. Medicare, Cytotech, and MD only. That's just the different, whether you use it just the Cytotech or if there's a doctor reimbursement included. Again, much better reimbursement on the thin prep. And if you go down the line, you can see that there's somewhere around a $10 improvement on reimbursement for the thin prep over the pap smear. Every single insurance company is going to reimburse higher. So now what you do is you apply the number of paps, and this is, you know what you had the year before. So if you just use those numbers, you can apply that. You know how many pap smears you had the year before. So if you apply your 40% and 60% division to that, you can get a total revenue expected for each test from each payer based on the numbers that you used the year before. And then you add them up and you get a total number of pap smears, conventional pap smears expected, a total number of thin preps expected, and then that's related to the amount of revenue from the conventional that you expect to draw and the amount of revenue for the thin prep that you expect to draw. And you bring those numbers down here. What's the actual cost of the pap smear? The number of paps that you expect, the annual cost that is incurred, and that's just the conventional pap smear, the cost of the conventional pap smear, multiply that by the number of paps, and then there's your annual revenue, which you determined over here. And then you can take the net profit loss there. And then we go, and you can see that we make approximately 19, right? No, 10, about $15,000-ish on that one. Then with the thin prep, you do the same thing, and you can see I'm sorry, with this one, you actually lose money with the $15,000. But with the thin prep, with your cost being more and your test being more, your annual cost is $162,000. Annual revenue, however, is $213,000. If you add all these numbers up, total cost, total revenue, profit loss, you're making more overall because you've instituted the new and better test. And you've managed to get 60% of your physicians to cross over. Now, based on the performance of this test, you might get more than that, and that would help improve your profit loss margin. This estimate has to be done because you have to predict if this is going to be worthwhile for the lab. Take your time and look over this. It's a lot of numbers. Another thing that has to be done is calculating the cost of equipment. This is done in different ways. One of the things, it's not necessarily done all that way, but I guess any hospital can choose the mechanism that they want to do. In this particular sample that we're looking at here, what we're doing is we're differentiating between the idea of directly purchasing the equipment or doing a reagent rental lease. A lot more hospitals are doing the lease plan because it's a lot easier. With most lease plans, one of the things that's included in the lease is the first year of service. This is just like trying to decide, do you want to own the car or do you want to lease the car? You have to figure out which one's more expensive over time. When you're a laboratory, you have to figure out um, whether or not this is going to pay to do this. And so some of the things that you can see is here on a particular instrument, they do 5 different groups of tests. You can see here you have group 1 for the anemia markers, group 2 for the tumor markers, 3 cardiac, 4 fertility, and 5 thyroid. They figure out based on previous years how many tests per year they have in each group. And this will be based on reagent costs. They figure out the reagents, how much it will cost them in the lease and how much it will cost them in the purchase. And you can see again, in the lease program where you're including service, you're including the service contract and the cost of the equipment, it's generally higher. The reagent costs are going to be higher. But then if you take those, so initially it might look like the purchase would be the better way to go. But if you then include in all of your calculations, usually over a 5-year period, although it could be a different period if your hospital wants to do over 3 or 8, whatever it is, now do the same thing, compare over 5 years the lease plan and the purchase plan. The reason we use 5 years is most of the time you can defer the cost of the instrument basically over 5 years, so that makes the most sense. So with the lease plan, you can see we're just extrapolating your annual volume times 5 years times the cost of the test over 5 years, and you can see your lease plan is going to be $10,000 for group 1 over 9 years. Essentially, for all 5 groups, it's going to cost you $285,000 over 5 years. If you go with the purchase plan, you have to take the cost of the equipment, $49,000, plus the service contract, which you're going to be paying for the first year is included in the contract, but then the next 4 years, $9,700 times 4 years, that gives you your $38,000 for the service contract. These are things that with the lease plan you don't have to pay. Okay, so include those plus the cost of your reagents times the 5 years, and you can see that you actually do save some money in most cases by going with the lease plan. And that's why many more institutions are going with the lease plan for this instrumentation for the 5 years. For the why does this benefit the the companies, the biotechnical companies? Because they're leasing to you. They know they've got a customer for the next 5 years. So that's one of the things that helps them. Then the final thing that we have to be able to do is to calculate the actual cost per test. And in this sample, we're doing an example of an HIV test, okay? So if you look at the information that's up here, we have a lab that bills 3,500 HIV tests per year. That's how many they bill. And they know that the reagents cost $30,000 a year. So, and that's based on a $500 kit where they use 60 kits per year. So based on that math, if we divide those two, we can determine that just in reagents, we're paying $8.57 per test. But that's not the end. That's just reagent cost. We still have to figure out all the other things. We know that the service contract for our instrument on which we do our reagent cost is $8,500 a year, and we're just going to divide that instantly by the $3,500, and we know that that adds $2.43 per test. Okay, so we have to include the service contract. Then these do not get done by themselves. You have to consider the salaries. Okay, how do we figure out the salaries for this? Well, salaries are generally determined not by how many techs work each equipment or anything like that, but we just basically do a rough salary calculation by dividing the total amount, the total cost of all of our salaries across the entire lab by the total number of billable tests that we run each year. That basically gives us the cost to run each individual test, and we're going to apply that here to our HIV test. It's not going to be different for any one test. So we take our total salaries and divide it. In this hospital, it costs almost $2 million, and then we're going to divide that by the 800,000 tests that we bill each year, and we get a cost of $2.41 that we're going to add to this HIV test. This $2.41 would be added to any other test in the lab. That'd be the same, okay? And then there's a few other tests, other costs that you have to include. Well, what about medical supplies, total billing? So this would be things like, for the medical supplies, what about things like the phlebotomy equipment that is used to collect the test, the tubes, and all the other equipment, the medical equipment that we use to run the test? Well, okay, we can figure that out. We take the total medical supplies. How much do we spend on all that stuff every year? And then divide it by the total number of tests. That's the easiest way to do it. You could get crazy. How many require phlebotomy? How many don't? It's really, that's probably too difficult to figure it out that way. So just divide it by the total billable tests. And then you see here, 24 cents you're going to add to the cost of that test. You're going to do the same thing for the non-medical supplies. So non-medical would be, it's interesting that it's the same amount here, but non-medical would be things like the, paper, the stickers and the all the non-medical stuff, sharps, containers, and stuff like that that apply to each test that's run in the laboratory. Apply it to each test. Okay, and you can see that you end up with, interesting, I must have written that number in wrong because that's not 5 cents. So I must have the non-medical supplies, that top number is wrong, and I apologize for that. So then you go with, but just to go on, so whatever the math was, they get 5 cents from that. Then other direct expenditures, and these would be things like your lab, accreditation, the other expenditures that are required, training for the test, anything that's required for that, for the hospital to run, for the lab to run. Again, total billable tests as well as travel and education. And you divide that by your total billable tests, and what you end up with, 6 cents for other direct expenditures, 2 cents for travel and education, with a final cost, if you add those all up, final cost per test, $13.78 per test. Again, look at these numbers, spend some time with them.